I'm excited about today's discussion. Um, so hospital-acquired infections is the theme of today's discussion. And whilst we could go down rabbit warrens, and I'm very happy to be guided by you, what I really want to use this session for is not to talk about antimicrobial resistance and emergence of antimicrobial resistance. I want to really talk about, I guess, shift mindset that we need to make as a result of antimicrobial resistance. So I think most vets that we work with still have an idea that we're treating infection. Like when an infection arises, we treat it. And as kind of antimicrobial resistance develops, we have to assume that there are going to be infections we can't treat. And therefore, we need to put more effort into preventing infections from developing. So in the human hospital system, they reckon that between 20 and 70%, depending on the facility, of admitted patients in a human hospital setting develops a hospital-acquired infection. Between 20 and 70%.
Wow.
So, and we'll talk about the risk factors like the hospital patients have. That's not necessarily the hospital's fault, but there's obviously things that we can do or not do which are going to decrease the risk of hospital-acquired infections developing. So I'm just going to show you a picture quickly. I lost it. About, and this is the only thing I'm going to make you look at about antimicrobial resistance. Are you just sanitizing, Helen?
No, I'm actually putting on hand moisturizer.
I was like, this conversation is making me feel a bit germy.
Very typical.
Because she's been sanitizing, now she needs the
That's
moisturiser.
right. That's exactly right. Okay, so um, sorry about the branding. This is a talk that I gave as part of Northside Vet Specialists, now TPS. But what this graph shows is when an antibiotic was first developed and then when resistance to that antibiotic developed. So if we look over the years, first antibiotics were sulfonamides, developed in the mid-30s, and by the mid-40s we had reported resistance. Penicillin, mid-40s. Before the 50s, we had reported resistance. Oops, daisies. And then if you just look down the list, you can see some sort of familiar names, and you can sort of see the pattern of like the period before resistance develops now is getting shorter and shorter and shorter. So I think what we probably have to face is that pretty much every single antibiotic that's been developed has now got resistance reported to it. So there are going to be infections emerging that we can't treat. Now, the other thing that happened around about the kind of 80s, 90s, 2000s is that pharmaceutical companies that were producing antibiotics were like, why would we put any investment in this? Because we produce a new antibiotic. Human hospitals know that we need to keep new antibiotics up our sleeve for those infections we can't treat with traditional ones. So you put all this money into producing a new antibiotic and it gets put at the back of the cupboard for use only in very restricted circumstances. Why would we invest in developing this? So there's a 20-year gap where new antibiotics weren't really developed, and you can sort of see at the end of the ciprofloxacin, it's a long time before anything new came out. So not only have we got shorter periods before resistance develops, but we've also got no new antibiotics coming through. So resistance is now developed to everything we've got. And there has been some public investment in production of antibiotics for exactly this purpose. But our mindset really needs to shift around. We don't treat infection anymore, or we may not be able to treat infection anymore, and we need to prevent every single infection we can to try and avoid being in a situation where we've got an untreatable infection. And that's where avoiding hospital-acquired infections is such a responsibility for us as clinicians, depending on the settings that you work in. Now, I think a lot of people think about managing antimicrobial resistance development as like being very careful about how you prescribe antibiotics. And that's true. That will impact the environmental organisms that you have in your clinical environment and on the patients that are coming in and out of your clinical environment. But there's so much more we can do with sort of facility management, understanding where different infections arise from, what risk factors we've got to try and prevent those infections. Does that make sense?
Yeah.
Does anyone find this shocking?
No.
No?
No. When the time's appropriate, I can I can tell you what happened at Tufts back in the 80s.
Mm.
And that is when they started their intensive care unit, they were right onto it right from the very beginning.
Okay.
Because the story with a lot of the American vet schools at that time is if a dog was admitted to intensive care, which wasn't Tufts because they didn't have one at that stage, basically you'd hang a black bag on its cage because it would get a hospital-acquired infection and die from it. And the way they stopped it, and there were papers full of it in the 80s, the same in human hospitals, was just to stop using antibiotics. But at Tufts, what they introduced is we were supposed to wear a separate pair of gloves between every patient. I say supposed to.
Yeah, it's hard to do, actually, hard to apply.
They blocked up all the drains to stop infection coming up from those.
Wow.
And if you wanted to prescribe an antibiotic, you had to put it through a committee. And you had to justify it. Like if it was a septic peritonitis, for instance, you had to have neutrophils that had bacteria in them from a tap, that sort of thing. Now, of course, we all know that if you do get that, you can't waste any time. And I just can't remember, but I think we could, like it was the middle of the night, we could go ahead and then put it through the committee in the morning. But other things are, yes. So we had an outbreak of salmonella. Yes, that's right. If a dog was admitted to hospital, it was admitted to a cage and it stayed in that cage the whole time, a dog or a cat. It was not swapped over. And we had an outbreak of salmonella, which affected quite a number of the staff. And it was traced because of that, they were able to trace it to the dog that brought it in and the cage it came from.
Yeah, wow.
So it was sort of groundbreaking work, and I think Bob Medical was he's
Tufts have led the way. Like a lot of the literature on antimicrobial resistance and hospital-acquired infections has actually come out of Tufts. So they've obviously been ahead of their time and learned from that experience.
Yeah, that was instigated by Bob Myrtle, who's now head of a new vet school in Texas.
Right. Yeah.
But the other things I've seen is suggestions is you don't, for hand washing, you don't use Hibiclens or anything you just use ordinary soap, pump soap. And a lot of practices have Hibiclens, and it irks me. But then another thing we've got to do is train the public. I mean, I saw a tick case. There's another story behind that too. I saw a tick case up on the Central Coast during the week, and I was explaining to the owner what was going on, and he said, "Oh, it's on antibiotics." And I said, "Well, no, because he hasn't got an infection, and antibiotics will have no influence on the toxin."
Yeah, and I think that there's been a lot of conversations around that in human health. So I think a lot of the clients are kind of getting a little bit more. I mean, the area I come from, there's a kind of alternative medicine or holistic medicine influence, and there's a lot of kind of probiotics rather than antibiotics. So I'm probably quite privileged in the clients I'm working with, but or was working with. But I think that's kind of happening. That influence is happening. Going back to the hospital, like specifically hospital-acquired infections, let's talk about what factors do at hospital admitted patients have that make them more susceptible to disease, to infection.
The sick, their immune systems are,
Right. Yeah. So compromised immunity, yeah.
or
And
they're stressed from surgery or whatever.
yes, good. So we've got stress, we've got compromised immunity from the underlying disease, or potentially medication.
Immunosuppressants.
Yeah, yeah. So a lot of particularly medicine patients are on some sort of immunosuppressant medications. You mentioned surgery, Jeff, stress from surgery. What other factors does surgery create which might predispose to a hospital-acquired infection?
Oh, well, there are wounds and
Yeah.
there's tissue damage, and the blood supply to them may be compromised
Yeah.
to a
If we
degree.
think about the immune system, a big part of the innate immune system is those physical barriers, isn't it?
Mm.
We've got the skin barrier, we've got the gastrointestinal barrier, we've got a long urethra with hopefully not too many binding sites for E. coli to climb up. There's a lot of physical barriers and flushing out of the urinary bladder because animals are going to the toilet often whenever they need to. There's a lot of physical barriers that we disrupt in hospitalized patients, but surgery in particular and catheters are disrupting that skin barrier and creating this passage for bacteria that lives on the skin normally to just get straight into places it shouldn't be.
Oh, that raises another thing from Tufts. They didn't, where everybody in Australia uses over the needle catheters, cannula.
Yeah.
In Tufts, we had to use through the needle. Um,
Oh, right.
and you could buy them here when I first came back, but I don't know whether you still can.
Mm.
And they had the other advantages that you could feed the small dog, you could feed them and place them just near the heart, so you could measure central venous pressure.
Yeah, that's nice. Yeah.
But of course, the difference is with an over the needle, it contacts the skin on the way through. A lot
Yeah.
of vets don't clean the skin adequately.
No.
And if we put a cannula in, it had to be as for surgery, is
Mm.
clipped, scrubbed as for surgery, and the whole limb had to be clipped,
Yeah.
not just where the catheter cannula.
Little patch. Yeah, and I think a lot of our catheter protocols have come from having a patient admitted for one procedure. We put a catheter in to last the day, and that kind of migration, you clean the skin and you get this little patch of nice clean skin, but over time you get migration of bacteria back into that site and that entry site to the catheter. So if we've got a patient that then all of a sudden needs to stay overnight or stay for 2 or 3 days, we've got to take completely different protocols, or should have used a different protocol when we placed that catheter, clipped the whole limb, prepped it for surgery, allowed drying time. Who does that when you're doing a catheter? Because that's actually a really important factor in disinfection, isn't it?
Yeah. I mean, their attitude there was if it was an over the needle catheter, it was 24 hours life.
Yeah.
Change it after that. Through the needle,
Mm.
3 days.
But then the morbidity of, like, you can run out of veins with a lot of medicine patients being in hospital for as long as they are, don't you? If you're changing it every 24 hours.
Yeah.
And then more opportunities for more infection to develop. Like if it doesn't look infected, you'd probably leave it, I guess. Or should we just have, I mean, we had a 3-day protocol in our hospital, but if it doesn't look infected, do we need to intervene? I don't know.
Well,
So whereabouts in hospital acquired infections, where do most of the infections come from? Where do the organisms come from?
From us and our hands.
or from a transfer from other patients.
Mm-hmm. Yeah.
And well, also, yeah, and as Helen says, the
Mm.
people involved as well.
Yeah.
And fomites from things that we're using as well, like our stethoscopes, thermometers,
Right.
everything that contacts the patient or the patient's environment.
Mm.
And spread via computer keyboards, door handles, all those things.
Keyboards are such a problem, aren't they? They're very hard to clean. So everything, interestingly, everything we've mentioned is exogenous infection. So everything that kind of pops to mind with like, what are we causing? How are we causing infection? Are those organisms that are coming from outside? But actually, the vast majority of hospital-acquired infections are endogenous. They come from organisms that are on the animal when they come into the hospital. So what sort of sources of organisms do we have on the animal themselves that we need to try and manage while we're doing invasive procedures?
Well, there'd be gut, there'd be skin,
Yeah.
coughing, if any.
Yep. Gut, I'm going to include mouth in gut because animals lick everything we put in, they lick it, don't they? It's one of the main
Yeah.
sources of infection. And they're dirty, their mouths are gross.
Yeah,
Um,
that's an interesting point because I would always think of that as like a patient-acquired infection, not a hospital-acquired infection, but it should be because if they're getting it when they're in the hospital.
yeah, so something we've done, like an animal should be able to lick itself without causing an
Yeah,
infection. But we
yeah,
do invasive procedures and things
makes
that
sense.
disrupt that physical barrier and make them susceptible to it.
Yeah.
And that's a big source, I think, where we can probably do better in prevention. Now that because E-coli is so distressing for most patients, but now we've got some of the soft donuts and things like that, and bandaging material and stuff that we can probably prevent a lot of hospital-acquired infections by making sure that the patient can't lick at anything.
Mhm.
Um, Okay, so if we go to exogenous infection, so things that we give the patient kind of thing, that they didn't come in with that organism, we put it on them. Um, so we mentioned us first, didn't we? Like what we take to the patient. So what's the most common organism that a human will transfer to a patient?
E. coli.
It's not
I was going to say Staphylococcus.
which stuff?
Um, probably like an aureus.
Yes, good, excellent. Yeah, so Staph aureus is the human staph. Staph pseudointermedius is the dog staph. So we're really colonized by these staphs that really like our own species, their own species. They don't like crossing over. I love this study. That somebody went to a veterinary dermatology conference and swabbed all the derm specialists and to see what they were carrying. And interestingly, um, methicillin resistant staph, whether it's aureus or pseudointermedius, has less preference for its own species. So
Oh, interesting.
isn't that? So
Mm.
they swabbed them all, and meth susceptible staphs were on their own species. So the humans only had meth susceptible staph aureus, and there was no meth susceptible staph pseudointermedius on any of the dermatologists, but 7% of them had meth resistant staph pseudointermediates. So it's better at crossing species. So for us, 30% of humans, and 30% is an old stat. It's 20 years old. So I'm sure it's more than that now, carry MRSA all the time. It's just now a commensal organism. It's so common. So if we know that meth resistant staph is going to grow better on our patients, then what we're carrying on our hands around our nares and things, I'm saying as I touch my face with my staffy hands. um, it's our responsibility to make sure that we're sanitizing well, wearing gloves, and doing what we can to minimize our carriage of those organisms. Where does staph live on us? I've sort of mentioned a few spots.
Yeah, like nasal passages,
Mm-hmm.
skin. I think yeah.
Yeah, exactly. Yeah. So it's most of the kind of mucocutaneous junctions and where there's like nooks and crannies, so like skin folds and stuff like that. Nail beds is a really big one, and it's exacerbated by like unhealthy cuticles, dry hands, yeah, all of these things that none of us are really putting a lot of time into. And interestingly, this is why some human hospitals have a policy that staff aren't allowed to wear nail polish because the nail polish people wear these days are quite thick and it creates this like groove right next to your cuticle where organisms just accumulate. So when you're scrubbing your hands or like sanitizing, the sanitizer doesn't really get in there very well. So just if you are wearing nail polish, just make sure you're getting right in that groove with either sanitizer or a scrubbing brush, and make sure that you're cleaning that well. Scrubbing brush without damaging your cuticles, which will make you more prone. So if us giving our staphy organisms to patients is a risk, what do we do to overcome that risk?
I mean, wear gloves.
Wear gloves. Yeah, great. And we do that in surgery, don't we?
And we try and do it elsewhere, but it's really hard. It's a really hard habit. It's really, really hard.
Really hard because I use my hands. I use that, like, this is part of my diagnostic process, is actually touching the animals, and my therapeutic process.
Well, yeah, that's right.
Yeah.
Soft fur.
Yes.
It's really hard. It's a really even yeah, I find it really hard. Even places when I'm like, absolutely, I should be wearing gloves, like changing a bandage or on a wound.
And
Chemo patients walk through the door and like, we've got such strict policies, and it's still hard to remember.
it is, and not just hard to remember, but also hard, functionally hard. Like, try and tape in a catheter wearing gloves. It's so hard. So one of the main things we do is sanitize. Oh, it's like scrub, right? And now we're using more sanitizer pre-op, but most surgeons are doing a full scrub at least once a day, right?
I
Yeah.
think so.
So I like this study too. Chlorhex should be in contact with the surgeon's hands for at least 2 to 3 minutes to thoroughly sanitize. What do you reckon the average amount of time that a surgeon scrubs for is?
Oh, like 1 minute.
Yeah.
Yeah, I was going to say 1 minute.
Yeah, it's never long enough actually to do the job.
You have to set a timer or look at the clock.
You do, totally. Yeah. And even if you're looking at the clock, I think like literally it has to be a timer. You're not allowed. And contact time as well, because you're like, oh, it's the 3 minute starts now, but I'm only at my fingernails. Whereas like down to here. So yeah, there's definitely a gap between what we think we're doing and what we're actually doing. And it's interestingly, that study showed that the degree of invasiveness of the surgery, the surgeon tended to scrub longer if it was like an X-lap or something. But if they're doing a cat castrate, it was like 40 seconds.
I mean, I feel that. Like,
Yes,
I think just yeah, absolutely.
makes sense. Yeah, I'm nervous about this one. I'm going to sit and stand in this thing for a bit longer and really make sure I'm clean. Jewelry is another one. So under rings. So if you wear rings to work often, just make sure you're sliding them up when you sanitize, or just put them in your pocket or on a necklace or something. And something that we can do is use sanitizers with emollients in them. So like Softerman has things that protect your skin while sanitizing. And so it's less likely to cause dermatitis and things which will predispose you to carriage of organisms.
And that's another reason just to use ordinary soap, because
Yeah, that's exactly it. Yeah.
Not for scrubbing for surgery, but just general hand washing.
Yeah, but it is tricky because between patients, you need to get the organisms that you got on you from that patient off you before you go to that one, and soap's not going to do it.
No.
No.
Yeah, no, it's not. That's well, at Tufts, as I said, we had to wear a separate pair of gloves for every.
Yeah, so if you're wearing gloves and just using plain soap, I think that's the best. If you're prone to dermatitis, that's the best thing you can do for sure. Nails, keep your nails like no more than 3 millimeters. I don't know.
So sad.
With
So sad.
nails. All right. What about, so we've kind of covered us as the source of infection. What about like our prep procedures for, like, say a patient is having an invasive procedure, so catheterization, venous catheterization, or like a surgery? What do? We anesthetize them, we lie them on their back, and then we clip them. Who's changing clipper blades between every patient?
Nobody.
Nobody. Absolutely not. How many organisms are you scraping off a patient's skin and then putting straight on your next patient's skin right as you're about to prep them for surgery? So many. Who's using designated clean clippers, dirty clippers?
Oh, I mean, we do have a pair that's labeled as dirty.
Oh yeah. How many times have you seen a member of your team clip a dag off a bum with the clean clippers?
I mean, I'm sure I've done it myself.
I reckon this is probably one of the things we're doing the most poorly in hospital-acquired infections. And it's something that we don't have data from the human healthcare system because most patients don't require clipping.
And if they do, they absolutely use a disposable razor.
Yes, exactly right. Yeah, it's completely
or
different.
disposable
It's
paper blades.
using it. It's actually really simple, but we do it so badly.
So badly, yeah.
Yeah.
And I think you kind of get a bit complacent because you're prepping them
Yeah.
straight after, right? So you're kind of disinfecting
And you're busy and you're like, I'll grab them in consult and clean this and then go back and yeah.
Yeah, but then you're holding the patient with one hand, you can't clean them, and you're like, I
Yeah.
just really think one thing. And
Yeah, it's bad.
yeah.
So
So
better.
I would encourage every single practice to just spend $1,000 on clippers and just have them absolutely everywhere. So at least there's like they're being used in less patients, at least. If you can't put like obviously have a protocol and have someone that's designated to like keep cleaning the clippers after every use, but
Almost needs to be like, with the ear cones, you have like, well, we always had like a clean dish where you took your ear cone, then you did the ear exam, and then you chucked it in like a dirty dish.
Yeah, that's a good idea actually.
Yeah.
And then, so if you had enough blades,
yeah,
you could have like a clean and dirty situation.
I like that. Except the I find the clippers with the changeable blades are always so loud and like
Yeah, although those tiny little burgundy ones, they do have changeable blades.
true.
And
Yeah,
so do those white ones that I find quite quiet. I mean, they don't last forever, but
yeah.
they do have changeable blades, so you can get extras. Yeah.
But apart
Okay.
from that, there's a lot of stuff accumulates in the actual body of the clippers as well.
Yeah, absolutely.
Yeah, and that, I mean, probably like they should be being cleaned probably daily, at the end of the day, probably.
Yeah.
Mm.
And sharpened as well, because how often do we cause abrasion?
The skin, yes.
Yeah.
Terrible.
And that's disrupting that skin barrier. How often do we see clipper rash and hot spots secondary to clipping? All the time. And as soon as you've abraded the skin, the animal's like, I am going to lick that the second you turn away. So then we introduce more oral organisms as well as the skin organisms in there, and it just ends up a big dirty mess. So everything you can do to use clean clippers, ideally clean blades for every patient, and really careful clipping. Like don't try and do it conscious, do it sedated, so that you're not like they're not wiggling and you're not catching a skin fold or a nipple or something like that every time you clip them. Autoclaving clipper blades. Who's ever done that?
Can you? Don't they have plastic? Someone
Oh,
should.
the metal ones you can.
Mm.
Why don't we do that? Such a hot tip. Okay. I don't want to go through surgery prep in any more detail. Does anybody have any specific questions? So, I mean, surgeon skin prep. Well, what we should talk about is the prep solution we use before surgery. Are we covering all of our organisms with our prep solutions?
I mean, there are some chlorhexidine resistant organisms, aren't there?
Sure are, yeah. What do all of your practices have protocols on how often the chlorhex swabbies that are already made up for prep are changed?
Oh, daily, also.
Daily?
Yeah.
Yeah, good. Yeah.
People pick these top swab off with their fingers.
Mm-hmm.
But yes, certainly. I know my father was saying in human medicine they traced an outbreak to an antiseptic bottle.
Oh, it happens all the time, Jeff. So if you've got a hospital-acquired infection and you swab a Pseudomonas or Serratia, which we're actually seeing is increasing frequency, and there's another one called Acinetobacter or something
Oh
like
yeah.
that. They all probably came from your prep solution. Pseudomonas is one that could be endogenous, but they're organisms that aren't necessarily very pathogenic, but they're just very good at surviving in adverse environments. And they'll take advantage of being the only organism there and make hay while the sun shines. So if you're getting hospital-acquired infection that you swab, culture, and Serratia pseudomonas, just review your prep solution protocol and make sure it's being changed daily, or you're making it up individually for each patient as needed. Yeah, those little catheter swabs, those huge like silver containers with like Chlorhex balls, cotton wool balls in there. I always look at them and go, oh, we only put in like 5 catheters a day. Why have we got so many balls made up? And whilst we're on perioperative sources of infection, radiology table. So a lot of patients have radiographs straight after surgery, and we carry them in and we put them on the radiology table with a wound. It's not an open wound, it's a closed wound. How long does it take for a wound to seal? So if you touch it with your hands or it touches a dirty surface, how long does it take before the organism can't just go straight down to the bottom of that bone that's just been cut?
At least 6 hours, I would think.
Yeah, it's actually 5 hours for a fibrin seal to form in a wound. So that very high risk period where, as you identified, Jeff, the cage is very important, the cleanliness of the cage, but particularly radiology table. How often do you just carry a patient in and the radiology table's still got the markers on it, still got fur on it from the patient before, and you literally put the patient down, like just wipe the table with your elbow as you put the patient down? We've all done it.
Yeah, it's true.
Yeah, and the stuff that's on those radiology tables is rank. So, and that wound should be treated as an open wound for at least 5 hours post-op. So put a bandage on before, or at least a cover on before you take them to radiology if you've got to do post-op radiographs. Or I don't know how, like practicality of like often you're doing radiographs on critical patients and stuff like that. Like having some sort of protocol where it's disinfected after every patient would be amazing as well. Telling your team, doing this talk to your team, it's amazing how clean the radiology table gets.
Just interests me, what I was saying that in the 80s, when a lot of American intensive care units had so many hospital-acquired multiple resistant organisms, and they stopped it by just not using antibiotics. If we were just to use ordinary soap, and my way of thinking, the answer is to have bacteria there, because we're going to have bacteria, there's no question, but we can't get rid of them all. That are nice ones, shall we say, that don't give the nasty ones such a good opportunity. Someone needs to do a study on that if it hasn't already been done.
So what's actually changed? So that has actually been done. What's changed is that the multi-resistant organisms are coming from the community. So where it was actually the hospital that had the population of multi-resistant organisms before, now carriage of multi-resistant organisms in community members is like 40%. So, and that includes dogs, and particularly the types of dogs that end up being admitted to hospital. So bulldogs, for example, almost all of them have MRSP because they've got chronic skin infections and stuff. So it's all well and good to not prescribe antibiotics, not use antibiotics in a hospital environment if you're the one developing the multi-resistant organisms. But if they're already just coming into your environment on your patients, that principle doesn't work. So it's now shifted because the carriage of multi-resistant organisms is such a big problem. That mindset has to shift in. We need to prevent transmission of organisms between patients, transmission of organisms between us and patients, and those organisms that are on the patients already, because they're nasty ones, getting into the patient in an inappropriate spot. So whilst we have to be very careful of our antibiotic use, it won't solve the problem of not getting hospital-acquired infections anymore. So we're talking about cleaning the radiology table and the cages really well. What are we going to clean them with?
I mean, we use F10. I don't know.
Yeah, disinfectant like F10 or.
Yeah. So I think the important thing is that every single antiseptic has organisms that it doesn't work for. So, for example, feline calesi, F10 and trigene don't do it. It's got to be bleach, and it's got to be bleach at a very high concentration. and that corrodes metal, so it's really good in your cages. Parvo is not very susceptible to Trigene or F10.
Yeah, you have to use the F10 at like a much, much higher concentration than normal.
Yeah, exactly. And if you're using the same disinfectant all the time, you're selecting for specific organisms that aren't responding to that. So if you're not varying the disinfectant that you're using throughout the hospital, then you're going to end up with a selective population of bacteria on all your surfaces. So even just having the ordering person alternating between F10 and Trigene when they order might be something that you could do to just decrease that kind of selectiveness.
I mean, hence my point about just cleaning them and not using an antiseptic,
Yeah.
and leaving everything there and not selecting out the susceptible ones and leaving the resistant ones.
Yeah.
But what do you clean with then? Just detergent or something? Don't you?
Yeah, soap and water, but
Detergent.
I mean, I'm theorizing, for sure. But I had an interesting experience in Germany because I used to have an ingrown toenail and it would get infected now and again, and I'd go to the local doctor who'd put me on antibiotics and it would clear up. It happened in Germany again when I was visiting my son, went to the hospital there, and what they did was they anesthetized it, they incised it, and there was no pus coming out of it. So they said, no, we're not using antibiotics. Well, they just, I think, put iodine on it and bandaged it beautifully and said, just look after it. And I did, and it came good.
Yeah. And that's exactly that shift in principle of not using antibiotics, not relying on antibiotics for infection, but using these kind of principles of infection management to decrease risk of infection, I guess.
Yeah,
Yeah,
I mean, I had other
drain into antiseptic and then keeping it covered. Yeah.
And that's
I had other personal experiences too, like at Tufts, where I remember we had a dog with a skin infection, and when I was managing it, I was just cleaning it with basic stuff and bandaging it. Might have been using wet to dries, I just don't remember. But then when I'd have 3 or 4 days off, the residents would start using antiseptics and antibiotics on it. And when I came back on, it would be infected again.
Yeah.
And I used to maintain that the best antibiotic for a cat abscess was Penrose drainomycin.
Yeah.
So surgical and physical management of it. And it's the same with dogs' ears. Rather than throw a whole cocktail of ear drops at them, clean the ear out and get rid of the muck first. Just syringe it with saline or whatever, and it makes a very big difference.
And you raise a good point in that. So antiseptics are not sort of targeted specific antibacterial, antiviral, or antifungal. They're kind of across the board. So antiseptics, we can kind of be quite broad, apart from there are some select organisms that are resistant to those antiseptics. But as soon as we start using antibiotics, we're actually targeting quite a narrow spectrum, wiping out those organisms and therefore decreasing competition for any other organism. And we've all seen like a Pseudomonas otitis externa secondary, like because we've treated a what is it called?
Malassezia.
Yeah. You treat one thing and you inadvertently select for another thing. So
that's less likely to happen if you're using these really broad spectrum disinfectants and antiseptics.
yes, exactly. And that's where things like honey and stuff management is so effective because it's very non-specific. It's just across the board, organisms can't live in such high osmotic environment, and you don't then get those secondary infections with other things that you haven't targeted. And you can't cover for everything. There's no product that's going to cover for everything. Okay, let's talk about endogenous sources of infection. So the ones that are on the animals themselves and how we can kind of minimize risk from those. Let's talk about skin first. We know that the most common organism is Staph intermedius on our patients, most of our dogs and cats. What are What sort of infections do we typically see if a staph gets into the wrong spot? We might see a skin infection. What's a higher risk?
You could see like a pyoderma that's difficult to get on top of, especially if it goes deep, so your topical therapies are less effective.
Yeah. Most common cause of disco spondylitis.
Oh.
Pyelonephritis, endocarditis. So if staph pseudointermedius becomes systemic, it can be quite high risk. It's only moderately kind of pyrogenic. It's got some sort of exfoliative toxins which enable it to lodge in places that it wouldn't otherwise. And it does have a leukotoxin, so we do get that kind of neutrophil breakdown and pyrogenic kind of activity. So the animals will be quite sick if they get a systemic staph pseudointermedius, but not as sick as if they got an E. coli.
Yeah, that's right.
Yeah. So sometimes it can kind of fly under the radar a little bit in the hospitalized patients because they don't get quite so pyrexic, they don't go fully septic kind of thing. And it's one of the most common like implant infections, isn't it? So it comes from the skin straight into like the TPLO plate or whatever it is. Now the tricky thing about this is that it's on like 40% of our patients that we're seeing in a hospital setting have MRSP, and as I said, that's an old stat, so it's probably a lot more than that now. And we've got to do surgeries on these patients, and often we don't get to plan it and schedule it and things like that. So we're scrubbing the skin with our prep solution. We're varying our prep solution, changing it frequently, making sure we don't have any kind of pseudomonas or anything lying in it. In humans, they get you to wash yourself with a chlorhexidine soap for the 2 days prior to any invasive procedure. Is anybody getting their clients to wash their dogs the day before surgery?
I mean,
I reckon it's a nice strategy. Don't you reckon? So then it's like you just decrease the organism load on their skin. And most humans are kind of prepped to do that in that if they've had any procedures themselves, they're thinking this is what I like. I know that I'm going to need to do that. And particularly bulldogs and the roly-poly breeds because they've got so much higher organism numbers on the surface of their skin. Getting the clients to get right in there with a chlorhexidine-based shampoo as a one-off before surgery is just going to decrease organism numbers if it's elective surgery, obviously.
That's a good point because I mean, many a times I've just tried to scrub for a catheter and it's taken me quite a long time because the first swab you use is usually comes off absolutely filthy.
Yeah, exactly. Yeah. And getting the clients to really focus on the surgical site. So we're going to be doing surgery on the knee. So let's like really make sure that the groin, the bum, and the knee, like anything that's going to kind of fall down to that area, is clean as possible. And then obviously the licking and the soiling is important. We need to avoid, particularly when we've got an open wound, licking and soiling. So if you've, for example, I think like knee surgery is probably the most common surgery that's done. We've like often in a referral setting, these patients have had an epidural. What are we doing to manage poo getting on their wound?
Well, probably nothing, but an enema would be a good thought beforehand, but then again, there's extra contamination being introduced.
Yeah. Yeah, and I don't know, runny poo is sometimes harder to manage than solid poo, contamination wise. Are we bandaging all of our post-op like hind limbs? If they're having hind limb surgery, should we be covering it?
I mean, yeah, do most people, I feel. I don't know.
Yeah, always the environments I've worked in, most of the wounds are covered.
I mean, I don't do surgery, but ours seem to go home with a bandaged leg.
So something that our surgeons have done with the disposable gowns is they just finish the surgery, rip the arm off the gown and put the arm up over the wound because it's waterproof as well. So they put the
Like a dressing.
dressing on, and then they put that over the top just for the period where the animal's not very mobile, not able to get themselves out to the toilet well. And while they're hospitalized, you can do your x-rays with that on. They can sit in their cage and that wound is protected from being exposed to whatever's on the surface of the cage.
Apart from the surgeon's bacteria that are on the gown.
Oh, apart from that. Good point. Dan.
If you turn the sleeve inside out, it might get away from that.
Yeah. I'm not sure if it's waterproof the other way around.
Well, it'd have to be, but not as good.
Yeah.
If one,
Well, it has to be waterproof the other way around because you don't want. In fact, I don't know. You don't want your sweat coming out of it, but you also don't want fluids coming into it. So it must be waterproof both ways, surely.
Yeah. True story. Okay, there's just a couple of organisms that we've talked about Staph pseudointermedius quite a lot. Has anybody dealt with an enterococcal infection?
I feel like we see a few UTIs that are enterococcus.
More and more. So it's a really, really common gastrointestinal organism, just normal flora in the gastrointestinal tract, which means that it gets into the urinary tract often. So any hind limb wound, any urinary catheter is going to increase susceptibility of a patient to an enterococcal infection. Does anybody know anything about the organism itself or why it's one that we need to be particularly careful of?
There's like new resistance to it.
Yeah.
I don't know if I can tell you much more than that, but there's like lots of emerging strains of resistance to it.
Exactly. So the special thing about enterococcus is it transfers resistance genes between organisms.
Oh, that's clever.
So you might have an infection with enterococcus and one develops resistance and then all of them have resistance. So where you might be at like in other organisms that don't do that, you might have one organism there that's like got resistance, but you wipe out the others and then the other one just dies eventually and it's not a big deal. One organism is not a big deal, but enterococcal organisms develop resistance really rapidly and they transfer those as soon as they've developed it, they transfer it to all their friends. They're just intrinsically resistant to aminoglycosides. They only respond to very high concentration of antibiotics generally. That almost always test as resistant to penicillins, but using penicillins in conjunction with whatever they are sensitive to improves response to infection. And they always are reported susceptible to TMS, but they're not. So the way that they behave exogenously is different from the way that they behave endogenously in the folate production or something fancy. But it makes them very hard to treat because you get this susceptibility pattern, which doesn't reflect how they're going to respond in a body.
I mean, correct me if this is wrong, but I have tended to notice that, when like an older antibiotic that people stop using because of resistance that's developed, and then no one uses it for 5 years or so, and then you test again and it's useful again. Now, I wonder whether we were to just stop making or stop using certain antibiotics for a period of 5 or maybe more years, and then swapping over after that period and banning the others, whether that
we lost them.
Well, I feel like that it requires a level of cooperation that the world does not currently have.
Well, I just think veterinary industry is almost impossible to instigate change in because it's so siloed. Like there's so many small clinics that are contributing to a big problem.
I mean, you'd have to instigate the change in the human world too, for it to probably.
True, but they're quite restricted in their prescribing guidelines.
Yeah.
So there's kind of legal ramifications for human doctors in Australia. So worldwide, it's a problem because you can go to Indonesia and pick up an antibiotic that you're not allowed to look at in Australia, over the counter with no prescription. Or I shouldn't say Indonesia. There's lots of countries where that's the case. So there needs to be collaboration worldwide from that perspective. But the human doctors are better, much better, and much more restricted. Like to be using cephalexin for a urinary tract infection, like that's demonstrated as an infection and stuff, like they're quite careful about it, I think, relative to the vets that I work with, and there's going to be different populations. But the other organism I want to raise, it's not an organism but a class, is the Enterobacteriaceae. Sort of an emerging pattern of resistance in the Enterobacteriaceae called extended spectrum beta-lactamase producing organisms. So what are the beta-lactamases?
Like clavulanic acid.
Yeah. Or whether the beta-lactam antibiotics, beta-lactamases are the things that the bacteria produce, which break down those.
Oh, I see. Yeah. Okay. Yep.
So this the Enterobacteriaceae that are listed as like high risk for this are E. coli, Klebsiella proteus, and they're organisms that we see really commonly in urinary tracts. And they're all Enterobacteriaceae, obviously, so they come from the gut, cause infection in whatever wounds or anything, whatever kind of immune barrier loss there is. And they're really hard to treat because we can't use any of our kind of first line, second line antibiotics, and often they're less responsive to like TMS as well. So where we used to see this, like it was kind of reported in like we've had 19 patients with this in the last 5 years. Now we're seeing, like I'm seeing several urinary like culture results that meet that criteria, particularly with E. coli. So it's just going to get harder and harder to treat. The nice thing about E. coli is that we can block binding sites with cranberry extract. There are other mechanisms we can use when it's in the urinary tract. But if an organism like this gets into a wound, surgical site, or a clipper rash or something like that, it's potentially going to cause a lot more problems.
Anna, if those extended spectrum beta-lactamase producing bacteria, are they susceptible to fluoroquinolones generally?
Depends on the organism.
Okay.
Not very.
Okay.
Just looking at this graph, sorry.
That's okay.
Sorry, not related. So the reason I wanted to look at this paper in relation to that question specifically was that for those dogs with ESBLs, extended spectrum beta-lactamase producing Enterobacteriaceae, the dogs that were treated with enrofloxacin had a 0 coliform count on day 3 of therapy. 38 days post-therapy, all of the dogs had multi-drug resistant E. coli. All of the dogs treated with enrofloxacin. And interestingly, multi-drug resistant E. coli it's not as pathogenic an organism as normal E. coli, or I shouldn't say pathogenic, it's not as strong an organism as normal E. coli. So if you've got normal E. coli and multi-drug resistant E. coli in the same spot, normal E. coli will win out in terms of competing for nutrients and things like that. So those resistant E. coli aren't very good at hanging around in the gastrointestinal tract. So it's not a really long-lasting resistance. But in the presence of antibiotics, they're we then select for those organisms. So if you, in your hospitalized patients, they're the organisms that your patients are shedding.
Yeah.
So so if you've got a patient in hospital and you know that they've had enrofloxacin in the previous month, you can predict that they're shedding multi-resistant E. coli organisms, and you're not necessarily going to be able to use enrofloxacin in that period because those organisms aren't going to respond to it. Food for thought. So the last thing I want to sort of talk about is the shift in human management of human infections, like Jeff experienced in Germany with the surgical flushing out and like physical decontamination rather than antibiotic use being that kind of shift. And I think a really good example of that is the way that cat bites are being managed these days. Who's had a colleague that's had a fairly minor cat bite that's had to go into hospital and had surgery? Ooh, sorry, my dog. The standard of care now for cat bites is if you get a cat bite, you go completely full GA, you get an incision where they cut right down to the bottom of the wound, they flush it all out, they make sure that there's no nerves involved, they scrub it back and everything. And then sometimes they'll put a line in and have you on IV antibiotics for 2 days to prevent the infection from developing. Because once the infection develops, so they're just making sure that all of those skin organisms or all of those oral organisms from the cat don't have a chance to set up shop in there. So they're taking a really hard line in prevention of infection rather than treatment of infection. Yeah. Because when sepsis develops from a cat bite, it's really, really hard to manage. And I think that's just a really good reflection of that kind of shift that we should be trying to prevent rather than trying to cure after it's happened. Okay, that's all I had to say.
That was very interesting, Anna. Thank you.
No worries.
Yeah.
Hopefully you got something out of it. There's really good prescribing guidelines now with antibiotics. So ADAP is an AVA initiative, and they've put out a really good like guidelines document, which I'll send around to everyone in the rounds list. Sorry to spam everybody. And there's some kind of shorter papers, summaries on antimicrobial usage, like first line, second line, third line, and in what situations you can jump straight to a third line, for example, like pyelonephritis sort of thing. So they're consensus statements on antimicrobial stewardship. So have a look at those as well if you're really interested. Thanks for coming.
Thanks. Have a good day.
See ya.
Thank you.
Bye.
Bye.